when it comes to retroperitoneal disease, specifically retroperitoneal, there's not a lot. There are organs in there, such as the kidneys, that obviously have a lot of things going on, but we cover those in other chapters. So we don't have a lot to talk about with disease, but we do have probably the most to talk about. Other structures, lymph nodes, there's a lot of lymph nodes back there, but really anatomy. And what makes it so difficult, and makes it difficult for me too, honestly, is this is anatomy that pretty much goes unseen on 99% of your patients. We don't see all these different layers they talk about in the book. And it gets a little confusing, especially some of the verbiage I read. I actually wrote it down. It gets really confusing, but so that's why I've drawn a picture here, and I'm going to try to go through it carefully enough, and hopefully have you guys get a decent idea of what we really mean by retroperitoneal. So let's go ahead and zoom in on my little drawing here. I'm very proud of this here. So I've got some lines to pop in here in a second, but in general, we're looking at peritoneal space. What do I have on there? Can I draw on this? Yes. In general, we're looking at the peritoneal space and retroperitoneum. Everything that's yellow, all these yellow dots, are different layers of fat. Back here, we have some muscle, a spine. I think you guys recognize kidneys. Oh, and I will say one thing about this picture is that it's not, let's see, this person's kidneys are too low. When I say that, normally if I'm seeing, let's say like this is the right kidney over here, I should be able to see some liver. Not this, that's colon right on top here. And then over on this kidney, I probably should see, definitely should not be seeing colon over here. And then, so it's not 100% accurate, but it's designed more to give you an idea of all the different compartments we have to worry about. So I drew in lines to, oh dear. Yeah, there they are. Okay. Drew in some lines to kind of help us along. And maybe I'll just go clockwise starting at 12 o'clock. That way I'm covering a few things that are not necessarily retroperitoneal, not necessarily what we have to talk about right today, but since they're in the picture, I decided to throw them in there. So this is anterior, posterior. That's the spine, so obviously that's the back. And let's see, let's make sure we understand and always remember that right is over there and left is over here. Posterior and anterior. Oh, I'm liking that. I think I made the, okay. The size of my pen is a little bigger. It makes me write better, but now I don't have as much room to squeeze in, so I have to be a little more careful, I guess. But okay, so I've drawn in here. Somehow I didn't shade it on both sides, but this is just simply the rectus abdominis, the six-pack muscles right here. And of course, they are connected by fascia. Remember, we have aponeurosis. Remember that word? Remember that? It was so fun. We used to talk about aponeurosis all the time, and it was joyous. So as we come down to the next line here.
I'm sorry, man. I'm sorry. Am I tripping here? Because if we got abdomen and spine, wouldn't the left and the right be the other way?
No, and I'm glad
right
you
here?
said, I'm really glad you said that. When we do imaging, see, for us, when we look at ourselves, we look at a mirror image, and a lot of people, including me, I have to really think about this sometimes. We see the screen as a mirror, and we think right is right and left is left. But it's really the patient. So when you imagine your patient laying down next to you, their right side is closest to you. So we always view CT, MRI, ultrasound as the patient is facing you or lying down, but basically more or less facing you. So make sure I'm saying this right. My right hand is over here, my left hand is over here. So normally, like for instance, we'll see, trying to use my paper. Well, when I draw a liver in, let's just draw a liver in for the fun of it right here. Whoop. That's my liver. That's my right lobe. This is my left. I blew your mind. That's okay. In fact, this is worthwhile. Stupid. My tab. There we go. Let's do CT abdomen, and I want a transverse view. Let's just bring that up a little closer. Right lobe, right side of the body. Number 5 is spleen over here, so that's left side of the body. And we look at ultrasound. Well, when we look at ultrasounds, rarely do we see anything like this. Sometimes with children we do. But yeah, left side is always depicted on our right. Yeah, yes, to your question. So anyway, well, too many things up. Okay. Let's see. So right, left, rectus, abdominis. The next line down is pointing. Small intestine, small intestine, small intestine, small intestine, small intestine. These are small intestines here. So it probably the ileum. But what this is actually pointing to is the outside of that. So that is visceral peritoneum. The next one is pointing to the other side of the cavity. And remember, when we say cavity, it's just like your teeth. It's always filled with something. So there is no space between all of this. This is all tightly squeezed in together. There's only spaces for the sake of drawing. And this is also why one reason why it's so hard to see everything we're going to talk about today. But in any case, the other side of the cavity, but just inside that innermost line is the parietal. Peritoneum. And The next one as well, actually, that's a double, it goes to here and here, because I wanted to show that it's both the same. This is still parietal peritoneum, but it's actually posterior parietal, we'll just put P, posterior parietal peritoneum. Even though it looks like we have some intestines back here, some of our intestines are retroperitoneal. Most of them are not, some of them are. So these are all the small intestine is intraperitoneal. This guy here, and this guy here, and actually this guy here are all retroperitoneal. We'll get to those in just a second, since we're going. Well, no, let's go ahead and jump over to this one. Now, both of these larger guys here are colon. This here on the right is the ascending, meaning going up, colon. This one over here is descending colon. I don't have a line for it. And we'll just figure that one out later. Ascending colon, and then also, and this is once again not the most accurate image in the world as far as what we're really going to find at the level of the mid kidney, but since it's not colon and it seems like small intestine, but it's retroperitoneal, it's in this retroperitoneal cavity, this must be about the second, what's it called, segment, I think, of duodenum. So the duodenum, second, third, and fourth segments, basically as it's going around the turn, and right before, and duodenum is a very short segment of intestine. For just a little while, it's retroperitoneal, and then it goes back into the, as it turns into ileum. No, jejunum, I'm sorry, as it goes into jejunum, and then it becomes, so these are all, nah, I'm not gonna write that down. Make a mess of things. I decided to include these little muscles over here. So that's obliques. And I'm just going to put 3 down. There's 3 muscle groups. Remember, there's internal, external, transverse? External, internal, trans. Yeah, I think so. I'm not an oblique guy. The oblique muscles, they form and basically more or less an aponeurosis back here and then an aponeurosis here. So remember, this is the one we talked about at the corner of our 6-pack. Oh, that arrow's slightly off. That's the aponeurosis, and then it forms another one back here. But basically, these muscles are attached to not bone, but they are attached to sheets of connective tissue. But that's neither here nor there because we're not really talking about that. Oh, I decided to throw this one in here. That is our part of our peritoneal cavity, but it is a site of possible fluid collection, especially if the patient is, the person actually has waves in their fluid. It's kind of weird. If they're laying on their back for a long time, which they oftentimes are, if they have ascites at all because they're sick, this is the paracolic gutters on both sides. Para, right next to the colon, so it's paracolic gutters. That's why they are called a paracolic gutter. Okay, so let's now we're going to get into stuff that's a little more relevant to this particular chapter. And golly, gee whiz, let's make sure I do all of this correct. Okay. This blue line that travels kind of below the paracolic gutter and then over the kidney. And how would this happen? Yeah, at some point, it's going to kind of connect all the way across and continues across all the way over to here and connects in the corners. I should say it connects, it merges with some other fascia planes. That one is the anterior renal fascia. Fascia as in fascists. Everyone's worried about fascists today. And the real fascists were just because you came here for a little bit of history, like Mussolini's Italy, and fascia is it's a bundle. Is that right? Now I can't remember entirely perfectly what it means, and so now I should shut up. But I think it's a bundle. It's a fascia. Okay, so anterior renal fascia, or also known as also known as Gerota's fascia. So there you go. Gerota's fascia is also the anterior renal fascia. So you can imagine this light blue going, connecting at the same point of the anterior renal fascia. There's an anastomosis right there, basically. That comes around and goes up over this muscle and over the spine and to the other side. That, of course, would be, let's make sure I'm saying this right, yes, the posterior renal fascia, also known as, and not very well known, so this is a word that you can pretty much forget, and also a word we just used the other day for another organ, Zuckerkandl. Or Zuckerkandl's fascia. Most people, I've never even heard of it before. So technically it's Zuckerkandl. Most people just call both fascias, anterior and posterior, Gerota's fascia. Or if you want to play it safe, just call it anterior and posterior fascia. And then you definitely won't be wrong. Then we have another fascia and another layer of fat. We'll talk about the layers of fat in just a second. The spaces where the fat is in. Let's see, that is purple. That, once again, kind of anastomosis at the same point as the other two fascias we've talked about, and then comes around over these lumbar muscles, and anastomosis again with the posterior renal fascia. And so there's just a little space in there. That is the transversalis fascia. That retrofascial. Of course, it's the one thing I didn't write down. That's okay. It is the transversalis fascia. All right. Just quickly as we go around the turn here, I pointed out a few things that you don't really need to know, but I figured I'd point them out. Of course, this is, let's see, this is spine here, and there's a spinal cord right in the middle there, which is I'm pretty proud of. The sticking out sideways is the transverse process. Ooh, almost forgot. Process, and then basically the middle of your backbone, sticking out, the part that you can feel right dead center is the spinous process. And then there's several muscles here. I kind of started drawing little planes in there that show that there's muscle. Oh gosh, just in general, you know what? It's right here in front of me. They just call them, in general, we call them the deep back muscles. There's individual muscles, but we don't need to know them. So, and speaking of which, they call it thoracolumnar fascia is another. Yeah, that's okay. We're sticking. Well, how about this? Transversalis fascia. Thoracolumnar. Thoracolumbar fascia is also another term for it. That is okay. Now, I'm sorry, I forgot to finish writing deep muscles, deep back muscles. This is our important muscle. This is the one we occasionally confuse as a tumor. This is the psoas. So I got a psoas. Yes, psoas muscle. By the way, a lot of muscles, including the psoas, especially the closer you get to the end of a muscle, you get more and more fibers running down the middle of the muscle. Well, that's the beginning of the tendon. So a lot of times in the middle of this muscle, you'll see like an echogenic dot in the middle, and you're like, oh my God, what is that? Well, all it is it's pre-tendinous tendon fascia planes connective tissue, but in any case, that's what that is. Oh, and I have one more muscle in here. Just it looks like the little tip of it is the very inferior tip of the latissimus dorsi muscle. Okay. So those last few things we kind of don't really need to know for this chapter, but it's good to know overall, which is, I'm not just wasting your time. Let's jump up to here. This cavity, obviously, peritoneal cavity. Fluid space or potential space. Now, I have notes down here for some of these. Let's just write this space. So I didn't leave myself a lot of room because it's oftentimes not a lot of room. It's not where all the fat is. The fat's kind of behind the kidney in order to protect it, not so much in front of it, because it doesn't need as much protection up here. You have your entire abdominal cavity up in front of the kidney or anterior to the kidney, so it doesn't need all that fat. It needs the fat back here for a nice kidney punch, protects it. So this space is smaller, but this is the anterior para with an A, renal space. I'm just going to put space over here. It looks like I didn't leave myself a lot of room. Space, space, and space. Okay. Anterior para with an A, renal space. Now, in your book, there is a quote. When I read it, I went and laid down on my bed and sucked my thumb for about 20 minutes because it was really hard. But actually, it's when you break it down, it's a completely accurate quote. It says, anterior pararenal space, bordered anteriorly by the posterior parietal peritoneum and posteriorly by the anterior perirenal fascia. So anterior by the posterior and posterior by the anterior. That's very confusing. So let's zoom in a little bit so we can see the, so this space here, I don't like that. Let's put a pretty color in there. I guess, oh, come on. I choose the color, but it doesn't really choose it. There we go, now we got it. Anterior pararenal space is bordered anteriorly, so anything over here up is anterior, by the posterior parietal peritoneum. Well, we had already said, where did we write it? Ah, there we said, posterior parietal peritoneum. That is not the blue, but the black line. Let's see what we have over here. Ah, I knew, and posterior by the anterior pararenal fascia. And I knew it. I knew something was wrong when I was doing it because it seemed like too small of a space. I mean, not too small of a space, but the wrong space. This side, I made a mistake. Sorry if you're drawing along here. Okay. Anteriorly by the posterior parietal peritoneum. Well, yeah, this is the posterior parietal peritoneum there. And then posterior, this space is covered posteriorly by the anterior renal fascia. So that's where that space is, and that's where the confusion will lie. Oh, now I've got to do something here. That's just going to drive me insane. Okay, I have to fix my line. All right, let's get back to regular colors. Okay, so that's the anterior pararenal. And then this one is, this is the fat that is actually in contact with the renal capsule, the kidney itself. I have a line going right to here, and that is the perirenal space. I have more to say on all these, but I don't have room to write it, so I'll write it somewhere else. Peri with an I, renal space. And then back here is fat only. There's no organ inside of this space, and that is the posterior para with an A, renal space. I will mention, there's not much to mention here. I will mention that, let's see, the psoas muscle. Yeah, the psoas muscle, the deep back muscles, the latissimus dorsi muscles, these are all not peritoneal. They're not even retroperitoneal. They're actually retrofascial. So they're not really in their own. Well, they're not in either space. They're kind of in their own thing, but obviously we're going to draw them in because it's all right there. So let's see. Let's see what my notes say, because I don't know if I don't want to write all of this down and just make a mess of things. Let's go back to the anterior pararenal space, that first one with the pink that I've drawn in there. Crosses midline, so that space comes all the way across. Dang it, I'm on the wrong side of the line again there. So should have given myself a little more room. Crosses midline, mostly fat, although pancreas, so it actually goes anterior to the pancreas, which is important. When the pancreas has pancreatitis, the most likely location for fluid is the anterior pararenal space. Second through fourth parts of the duodenum, so yeah, the duodenum is in the space as well here. Ascending and descending colon. So ascending and descending colon are all, I guess I could, I move stuff around, I'm all confused now. Let's just get this color back. Okay, good. Technically, if it's behind the peritoneum, yeah, if it's behind the peritoneum, I don't know how to draw it across here, but you know, the same thing over on this side. All of that is anterior pararenal space. Okay, that just started getting ugly, so I'm going to get rid of some of that. Okay. So yeah, pancreas, second, third, fourth parts of the duodenum, ascending and descending colon are retroperitoneal. And then on a subset of that, in the space subset of that, is anterior renal, pararenal space. The perirenal, so perinephric fat is this fat here, and this fat there, and you know, there and there. That is perinephric fat. Let's see, bordered anterior. And this is a little better to swallow. Anteriorly by the anterior renal fascia, and posteriorly by the posterior renal fascia. Superiorly, so if we go farther up the body, this fascia comes together and merges. So superior to the kidney, superior to the adrenal gland, the fascia comes to like a point, like a pointy hat at the top. Inferiorly, it's actually open. So which is one reason why, well, I'm careful what you say, Kurt, but it's open. It does not merge inferiorly. It merges on the side, of course, over here, and then superior, just simply not inferiorly. Kidneys, adrenals, aorta, and IVC. So I've got the aorta here with a little renal artery. I have the IVC here. I didn't draw any veins going off there, but those are, so once again, still retroperitoneal. We're just talking about yet another space within the retroperitoneum. And so that is the perirenal space. And then the posterior pararenal space, the only thing in here, and we're talking about this area here, the only thing in there is fat. So generally, not much happens there. And I already mentioned the retrofascial space. Oh, let's look at this, because these drawings look so different. When we look at the body cut off like that, seems like this retroperitoneal space is huge. I mean, it looks like it's half of the abdominal diameter. And I think that's a little artistic license because when we look at a sagittal, mid-sagittal view, so you're not seeing the kidneys because we're dead center, we are seeing the aorta, so I guess we're not dead center, we're slightly to the left of the body. Let me draw in. Let's see, do I have a pretty color? I do. Okay, we'll draw in. Let's, we'll start here. Let's see, over the pancreas. Duodenum. That's duodenum right there. I'm gonna go over that duodenum. And then down, 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 down. To there. So let's see, transverse colon is all the way out here, nowhere near the posterior retroperitoneum. But as the ascending and descending go up and down, they actually will come back and follow back down. And in fact, the first part of the rectum is retroperitoneal because it is behind the peritoneum. The, I guess, last part of the rectum down to about this level and the bladder are subperitoneal, because if we're going to follow along and do this peritoneal cavity to here, now we're not retroperitoneal because we're not behind the peritoneum, although we're still outside of that cavity. So we can call it subperitoneal, or I've also seen it written as extraperitoneal. So, you know, I mean, I think I've even said the bladder is retroperitoneal. The kidneys, the ureters are retroperitoneal. The bladder technically isn't retro because it's simply not behind. But anatomically speaking, it is still kind of the same thing. It's not behind it, just below it. You know, just a little bit of difference there. Okay. So you can imagine, you put your transducer, let's see, you put your transducer right here. You look, idiot. You look down, and it can be hard to see because we have stomach, transverse colon, intestine, all that stuff, and possibly a lot of adipose tissue on a lot of people as well. It can be hard for us to visualize the retroperitoneum. Oh, and you know what? Let me just write down really quickly. I think I've done this before. Let's get away from me. No one orders a renal exam anymore. We get more money for the retro. Well, we also see more, and perhaps we'll do a renal exam on a follow-up, but never as a first view, because a renal exam is simply that, kidneys. Retroperitoneal is aorta, IVC, technically pancreas, but let me pancreas question mark, because I have never been specifically, that's never been a part of my facility's bag of tricks, protocol is to do the pancreas, although it is retroperitoneal. It is an organ in the retroperitoneum. If insurance companies are requiring it, you should be doing it. So we'll have to look at that. See what the ICD-10 code is for that. Aorta, oh, of course, well, kidneys. kidneys, bladder. Anything else? Nope, that's it. And bladder is even, well, it's not retroperitoneal, but you should always do it. You can pretty much guarantee that's what the doctors want to see, is kidneys and bladder, not the aorta and the IVC. All right. I'm really liking my picture today. Let's see, 142. You know what? We'll talk about just lymph, and then we'll get into, and we'll take a break. I'm really loving that picture. Oh yeah, so proud of myself. I figured out it was a new pen on my program here that really helped me out. Because it just depends with this pen, it's how hard you push from very light to very hard. It tends, anyway. So let's see, I did not teach you A and P. I'm not 100% how much you got of this. I always make sure I talk about it. So let me quickly talk about what goes on here. And this is outside of your chapter, but it's definitely worthwhile. As the artery comes in and becomes an arteriole, as it gets smaller, it's an arteriole, and then as they branch out into multiple, this is the capillary bed. So this is capillary, or as the British say, capillaries, which drives me insane. Arterioles, of course, they're muscle. Well, all the arteries are muscle, but this is where you get vasodilation and vasoconstriction. It's mostly in the arteriole because that's what it does. But in any case, let's see. Blood pressure is not necessarily high, but it's up. It's 120 over 70, whatever. Your blood pressure is high here, and then blood pressure here is pretty much, let's see, how do we do a 0? That's 0. And what that does is it forces fluid out into the interstitial tissues, So basically the cellular products around here, the in-between cells, water and because water is being forced out. This isn't just osmosis, it's forced out because of high pressure at one end, lower pressure at the other end. And it's being pushed out here and then brought back here. So actually, let's do this. And it's a little smaller though. Let's see. H2O and proteins and nutrients and dissolved gases and sometimes bacteria or whatever. Everything's being forced out, but then comes around and it's able to go back in to the low pressure veins, because literally the pressure outside in the interstitial tissue is actually higher than the venous pressure. And so fluid is forced back in here. But this is where our lymph does its work. It has a bunch of blind ending channels that start inside of the capillaries. And so lymph is basically blood serum. It looks like blood serum. It's kind of yellow. It basically is blood serum, and it could have waste products in there. It could have some bacteria in there. Anything that, a lot of things that you don't want to clean out of your body, that goes into the lymph system, and so the system travels upwards, of course, into lymph nodes, where inside of the lymph node we have, well, the lymph node is a filter. It is part of the, remember the term, reticuloendothelial system, so it has white blood cells in there that phagocytosis, perform phagocytosis. In other words, they're eating bacteria, or they're eating little waste products that are or cellular components that are no longer in use. And it also produces lymphocytes, the white blood cells that travel throughout the body and attack foreign invaders. So that's what happens in the lymph nodes, and that's one reason why we get lymphadenopathy, because either you have a bacteria or maybe even metastasis from a cancer going in to these lymph nodes. And when that happens, when a node has bacteria in it, well, it creates more lymphocytes, it gets bigger, and it fills itself with lymphocytes so it can attack as many bacteria, a little infection, or metastases as it can. And then in the end, there are two major ducts in the body. Both of them are up in the subclavian, the right and left subclavian veins, and that's where the lymph fluid goes back into our system. So that is our lymph system in a nutshell. Yeah, so let me just finish up with this before we take a break. I've drawn a few very simple lymph nodes here. This is a sagittal view right here of a lymph node. A lot of times they're bilobed, even trilobed. They look like peanuts, and every once in a while you get that awesome peanut with the boop, 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 3 peanuts in there. They look like that too sometimes. On transverse, they look a bit like a kidney, and they have this. Well, and on both sagittal and transverse, you'll be able to see a echogenic fatty hilum. At least you hope you do. And then sometimes they're round, but even then, you'll still see like a little hilum in them. Kind of a hilum here. And you'll see that kind of the hilum along here. But in any case, you should see a hilum. In the retroperitoneum, we find, not always, because they're small, but we find lymph nodes all around the aorta. I realize now that that's not such a clear image. What am I read? Oh, I just ran over a couple of. Oh no! All right, you get the idea. I'm not gonna waste your time. Aorta. Here, I'll just do a little bit. Okay, done. No more wasting time. All around the aorta and the IVC, behind the aorta, behind the IVC, are lymph nodes. And so when we do see lymphadenopathy, boy, I mean, these lymph nodes get bigger. It's going to lift that aorta right up over it. Or the lymph nodes between the aorta and the SMA, that's going to lift them right up too. So that's why I say we pay attention to how the SMA looks and how the aorta looks. If it deviates from normal, why? Not always lymph nodes, but oftentimes is. Now this is supposed to be spine down here. That looks horrible. Okay, so lymphadenopathy, or just sometimes called adenopathy, but I prefer lymphadenopathy myself because I don't know. Lymphadenitis is that's more like a bacterial infection, viral infection. Let's do bacterial, viral infection, lymphadenitis. They will increase in size. but they will maintain generally a hilum. In other words, that fatty hilum, these guys get bigger, but you can still see the hilum with lymphadenitis, so bacterial and viral infections. Malignant, and we worry about those, obviously. One thing with we're going to learn real soon on breast exams, we go up into the, we look around the outside of the breast, and especially up in the armpits. There's a lot of lymph nodes up there, and metastasis goes preferentially to the closest lymph nodes. It's not going to find a breast ultrasound or a breast metastasis is not going to find itself, all the way down at the lower aorta. It's going to find itself wherever that bed of lymph goes to, and generally, like I said, generally in the armpits. Primary, malignant, let's do primary, like lymphoma. Small handwriting here. Malignant primary lymphoma, that is, they are going to turn round. And it says hypo to anechoic, but I'm going to tell you anechoic, black. And no hilum. Can't see the hilum anymore. Rounded. Oh, and I forgot. Also, can't spell asymmetric. Asymmetric. So instead of being shaped like that in transverse view, well, first of all, they're going to lose their hilum. Let's say you kind of get a little bit of a hilum, and then, actually, no, let's do a sagittal view. Sorry, I'm messing around. That would be asymmetric thickening. So we don't like to see asymmetric thickening, because that basically kind of think of it as a little mini mass on top of that lymph nodes. So those were the primary, and then Mets is very similar. What's the big difference? Same thing. They grow big, loss of hilum, but they tend to be heterogeneous, or as that doctor said the other day, heterogeneous. I don't know if there's a consensus on that, but I like heterogeneous. But in any case, large, round, loss of hilum, those are things you're going to be worried about. Okay. I think I need a little more room on the side, but other than that. Okay. Yeah. Let's see. We just talk about. Take a break. It's basically 2 o'clock, so we'll see you at 2:15, guys. Controlling this, and I never know which way I'm going. But so I do want to, I'm going to make a personal. Personally, I'm going to start looking a little harder, because I think I should be. Because things can happen back there in the retroperitoneum. It's far away, it's difficult, and if you're not looking at a specific organ, it's just, and then you wonder, am I really looking at the retroperitoneum, or is that just the posterior peritoneum? And anyway, so you know, and I had to, as a reminder right on my screen, and I still look past it. Retroperitoneum, retroperitoneal fibrosis. That is, yeah, I've definitely seen it a couple of times, but like I said, I didn't really focus in on the retroperitoneum. I focus in on the aorta. That's where you see this. So if you find let's say a transverse aorta, and that's a pretty color, and around it just seems to be hypoechoic stuff around there. I guess I don't want that on there. You could be looking at retroperitoneal fibrosis. Most of it occurs around the aorta. And it's also called Ormond disease. Most cases of retroperitoneal fibrosis are idiopathic. We don't know. In other words, question mark. We don't know why people get it. Other people can get it though from, and even the idiopathic, it's probably oftentimes autoimmune disease is a possibility. Infections that get into the retroperitoneum. See if I made my pen too big. Infections, I'm going to do slash. Inflammation, and also just infiltrating, spreading cancer. And that's actually kind of like, I don't know if you guys remember, the omentum can get what's called omental cake. And that is metastases just floating around in the peritoneum and likes to attach to that omentum. This would be kind of the same thing, except it would be caking around the aorta and in the retroperitoneum. I'll make my pen a little bit bigger and see if that improves my handwriting again. Should have wrote down exactly the parameters when I had good handwriting with this program. As well, I mean, that's about it. Actually, no. Oftentimes with retroperitoneal fibrosis, the ureters are they're compressed, so there's a mass effect on them. Why can't it obstruction? Really, they're nope, still not good handwriting. That's really weird. Anyway, ureters are obstructed, and that's from a mass effect. So if the ureter is coming down very close in here, and you have this stuff creeping all around it, it's just going to squeeze out the ureters. And of course, from that, you can get hydronephrosis. So, peridoral plaque. Okay. Okay. That's about all I got to say. There's some images of retroperitoneal fibrosis. It can look like a whole bunch of lymphadenopathy, and perhaps it would be hard necessarily to know the difference in some cases. So primary neoplasms are not terribly common in the retroperitoneum. The benign are the lipoma, which is, of course, that's fat tissue, or a fatty, or a neoplasm from fat. The the leiomyoma, which is smooth muscle in origin. I'm just going to put smooth. Let's see, what was the next? Oh, the rhabdo. Whoops, did I spell that? Yeah, rhabdomyoma. That's more of striated or skeletal muscle. I'll just put, well, it's not necessarily because a lot of times we get heart rhabdomyomas, you get those in the heart. So I'll put striated muscle, any muscle that's striated. So heart muscle and skeletal muscle. That's really what I'm trying to say, I guess. Rhabdomyoma, what's the next one? Oh, myxoma. And that's a mix of, no, it's just kidding, that's not why. That's certain types of connective tissue. And the last one is a fibroma. And this gets very confusing when we talk about female in uterus. Sometimes they'll call them leiomyomas, sometimes they'll call them fibromas. I don't know, but a fibroma is also connective tissue in order, slightly different connective tissues, but so those are the benign. And then for the cancer, well, liposarcoma. Leiomyosarcoma. Rhabdo. Whoop. Brady. Myosarcoma. If I back off a little bit, my handwriting will improve. And then, of course, the mix. Oh, yeah. Myxosarcoma and fibro. That's the weird thing about cancer. All cancer is just regular body cells growing out of control. Benign, the difference between benign and cancer is really a matter of degree. Benigns don't kill you, they never will, at least not through infiltration or metastasis or anything like that. And then, but the cancer is just one step up. So the liposarcomas, those are number 1. And the right? Yeah, the leiomyosarcomas are number 2. So these are, so the first one of all the cancers, the primary cancers, these are not including metastases. The primary cancers, this is 95%, are the liposarcomas. These tend to be slow growth. So not all cancers actually kill you. Some of them grow so slowly that given enough time they'll kill you, but they're so slow that you might die of something else first. Let's say growing for decades, mass effect, not infiltrating. These non-infiltrating. That's a good thing. In other words, they grow bigger and bigger and bigger, but what they don't do is get these little growths. A lot of times cancers will do this. They'll grow out into other tissues Non-infiltrating, what? It will not do that. It'll just continue to grow larger and larger. And I don't believe these guys, and without infiltrating, oftentimes those tumors will not metastasize. There's too many Z's there. Metastasize. Will not create distant tumors. It will stay where it stays. And then we have the leiomyosarcoma. Obviously, if the other one's 95%, this is going to be somewhat less than 5% of the primary cancers. And this is a little worse. Leiomyosarcomas we could also get in the uterus, the GI, the IVC, and this one will have mets. So by the time you find it, it probably already has spread to other organs. I think both of these, especially the first one, can get huge. Partly because especially this one, I wish I wrote that down. It is this one, it's got to be this one. It can get huge, the first one, the liposarcoma, because they grow slowly. Organs have a chance to get pushed out of the way without you even noticing it. They start in the back and they have to work all the way up through the belly before organs are pushed in such a way that this becomes palpable. So by that time, it might be 20 pounds, which is a great way to lose weight fast. Okay, so as far as neoplasm, that's it. Fluid collections, we have a few of those. There's the anterior pararenal space. So remember, that also included, that was also not only the, included pancreas. Pancreas is in there. So your book says, all right, let me just start with pancreas. So a pancreas, golly. Started out so well when the handwriting was beautiful. I can't do it anymore. Pancreatitis. Pseudocysts can occur in the anterior pararenal space because the pancreas is in the anterior pararenal space. Your book also mentions possibly an appendix. Now those can become large and create fluid and everything. But that is a retrocecal appendix. That's an appendix that sits behind the cecum. Perirenal space, that's where the actual kidney is. So you can imagine if you find fluid in there, it's from the kidney. And so that could be nephritis, a bleed, of course, so like a renal artery rupture, perhaps an aneurysm ruptured of the renal artery, or a urinoma, urine getting outside of the collecting system and into the perirenal space. Obviously not a good thing. And then the last one, the posterior perirenal space, there are no organs in there. So pretty much the only thing that's going to get in here is a bleed, perhaps from an aortic aneurysm that ruptured and somehow ruptured into the posterior perirenal space. And I say somehow because I'm not sure how. And then, yeah, okay, guys, hang in a little longer. I see some antsy people. I could see some people looking at their phones. Don't worry, I do it on Zoom meetings too, so I don't blame you. I won't call anyone out on 100. Anyway, so fluid in general. In other words, a lot of these spaces up here could have any of these. So there's the hematoma. Those are, they could, well, obviously they can cause from trauma. Well, let's write that down. Trauma. Neoplasms, both benign and cancerous, are more likely to bleed because they have neovascularity, new growth, and a ruptured aneurysm. So aneurysm. Oh, I actually spelled it right. That could pretty much, those could happen in pretty much all the spaces there. Let's see what else we have. We have the lymphocele. That is going to be anechoic, and that is going to occur most often post-surgery. We already mentioned urinoma. That is most likely going to be found in the with an I, renal space, because that's where the kidney actually sits. So urinoma is any urine that gets outside the collecting system will create a little fluid pocket. And then, of course, our favorite, which we see all the time, abscesses. That could be retroperitoneal, intraperitoneal, and those are, of course, there's infections. They can be from, well, gosh, your book said diverticulitis, but how would diverticulitis get in the retroperitoneum? Oh, because of course, yeah, because you get diverticulitis in the colon, and that colon is retroperitoneal. So diverticulitis, Crohn's disease, that too. That too, remember, the Crohn's disease is a large intestine that is in the retroperitoneum. And like I said before, possibly an appendicitis, an API, if it is retrocecal. In other words, rather than going out in its normal position, extending out into the peritoneum, if it sits behind the cecum of the ascending colon, then I guess I never thought about it until I read it just this morning. By definition, that would make it retroperitoneal. So that would be a way of getting fluid into the retroperitoneum from an API. Look at that. Look at the difference in handwriting from here to here. What did I do differently? It's about the same size. I don't get it. I don't get it. Same pen and everything. Anyway, questions? Comments? Let me stop recording.